The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Sanford here to review the management of all things pancreatic cancer.
Hi, Catherine. Thanks for having me. My name is Dominic Sanford. I am a hepatobiliary and pancreatic surgeon here at Washington University, and it's great to be here.
Dr. Sanford is an assistant professor of surgery in our Department of Hepatobiliary, as well as the director of our Surgical Prehabilitation and Readiness Program. Today, we're going to be talking about pancreatic ductal adenocarcinoma. This is the third leading cause of cancer-related mortality in the U.S., with a 5-year survival rate of only about 10%. However, for patients who present with surgically resectable disease, 5-year survival can exceed 40%, making it a very important topic for your HPB and surgical oncology rotations. We'll review ways to diagnose and stage pancreatic cancer, important treatment steps, and the highly testable complications of typical pancreatic surgery. Let's dive into a case scenario that will serve as our template for discussion today. A 65-year-old male presents to the emergency department with a 6-month history of progressive weight loss, and now has noted that he's become progressively jaundiced. Given a patient who's presented with a concern for biliary pathology, what steps do you take to help in diagnosing this patient as far as laboratory and imaging steps?
Well, one thing that stands out about this patient is the chronicity. So this is something that's been going on for about 6 months, as opposed to him coming in, he felt fine, and then acutely had abdominal pain and, was turning jaundice. So that concerns me more for the potential for malignancy. But that said, we need to make sure we rule out benign causes of biliary obstruction as well. I'd start off with some laboratory studies, including a CMP with hepatic function test to evaluate for evidence of biliary obstruction, which would be made evident by elevated AST, ALT, bilirubin, as well as fractionating the bilirubin to look at direct and indirect levels. When you start talking about or thinking about malignancy, one could consider ordering tumor markers such as CA19-9 or CEA level. However, CA19-9 is not a great screening test in this setting because if we're worried about obstruction alone can cause the CA19-9 to be elevated. So I think that starting with a CT scan, specifically a triple phase abdominal and pelvic CT, would be a good first step. You could also consider an MRI with MRCP as well.
So you go ahead and obtain that triple phase CT scan, which demonstrates a mass in the head of the pancreas. It's hypoattenuating and concerning for malignancy. Additionally, the patient has a dilated common bile duct and dilated pancreatic duct. So let's talk briefly about the role of ERCP and EUS or endoscopic ultrasound for patients with a pancreatic mass.
So ERCP and EUS are very commonly performed in patients with pancreatic mass, specifically a pancreatic head mass. And the reason is because they're often done together. They provide both therapeutic benefit in the form of ERCP, which allows you to perform biliary stenting, which can relieve jaundice and alleviate symptoms of cholangitis. And the EUS allows one to obtain tissue in the form of a biopsy of the mass to establish a diagnosis.
Our patient undergoes an ERCP and placement of a biliary stent for drainage, as well as an EUS and biopsy, which confirms our diagnosis of pancreas cancer. What imaging findings do you consider in your categorization of pancreatic cancer?
Well, that's a great question and a question of a lot of debate. Resectability really depends on the involvement of the mass with local blood vessels, specifically the blood vessels that are of concern and are the superior mesenteric vein / portal vein, hepatic artery, and the superior mesenteric artery. So resectable involves where the superior mesenteric vein is being invaded by the tumor by less than 180 degrees, and the superior mesenteric artery is not being abutted, and nor are there any other major blood vessels being abutted. Whereas a borderline resectable tumor, you're seeing that the superior mesenteric vein / portal vein is being encased by more than 180 degrees, as well as there's often abutment of the superior mesenteric artery or common hepatic artery, though by less than 180 degrees. I kind of think of it as anything more than that is locally advanced. And then obviously metastatic disease, you're seeing signs of spread in either to the peritoneum or the liver, which is the most common site.
So for those patients who are showing up with locally advanced or borderline resectable disease, what is standard treatment?
Standard treatment for patients in those categories involves neoadjuvant chemotherapy. In younger or fitter patients, we usually do FOLFIRINOX chemotherapy, whereas in patients who are maybe a little less fit or older, a lot of times we'll do gemcitabine and paclitaxel or gemabraxane. My kind of rule of thumb is I usually do about 3 months of chemotherapy and follow it up with interval imaging to assess for response, and then proceed from there in order to consider surgery.
So our patient successfully completes neoadjuvant chemotherapy and has had some regression of his disease on his most recent CT, as well as biochemical response in the form of an improved CA19-9 level. And he returns to your office to discuss therapy. Based on the location of his cancer, what surgery would you recommend for him, and what does that entail?
It sounds like this patient would be a candidate for a Whipple procedure, which involves a resection of the pancreatic head, distal common bile duct, the duodenum, the proximal jejunum, sometimes the gastric antrum, and then reconstruction in the form of 3 separate anastomoses, those being a pancreatic jejunostomy, hepatic jejunostomy, and then either a duodenojejunostomy or gastrojejunostomy. The Whipple it would be performed in this setting, but if the tumor was located in the pancreatic body or really anything to the left of the superior mesenteric vein, then he would be a candidate for a distal pancreatectomy with splenectomy. We do a lot of, in the setting of cancer, we perform what's called a radical antegrade modular pancreaticosplenectomy, or RAMPS procedure, which just takes more care to respect the tissue planes of the retroperitoneum and provide better lymph node and margin clearance.
Our patient undergoes a successful Whipple operation and is recovering on the floor post-operatively. However, he has difficulty advancing his diet with persistent PO intolerance, nausea, and vomiting. What complication can this represent?
This sounds like you'd be concerned about a delayed gastric emptying, which is one of the most common complications after a Whipple procedure, occurring in about 20 to 30% of patients, depending on exactly how you define it. Most of the time, that diagnosis is clinical. However, you could perform an upper GI with contrast, and that would demonstrate delayed gastric passage. This is unfortunately a complication that really is managed with a tincture of time in most cases. Sometimes it takes several days, sometimes even a few weeks for the stomach to really fully start to work as it should. There are sometimes rare instances where we need to place a gastrojejunostomy feeding tube in order to provide both gastric decompression as well as distal feeding.
The other commonly tested complication of a Whipple procedure is the pancreatic leak. Can you discuss briefly how this is diagnosed and managed?
Yeah, so pancreatic leak has the definition of this has undergone a lot of revisions in the last several years. So, when you perform a pancreatic jejunostomy in patients, especially those who have smaller pancreatic ducts and softer pancreas glands, are at increased risk of leakage from the anastomosis. And so we usually diagnose this by checking a drain amylase level. Often you'll see the character of the fluid in the drain turn from a serosanguinous color to a more kind of turbid or murky color as well. Grading of pancreatic leaks or pancreatic fistulas are divided really into 2 broad categories. There's a biochemical leak, which is simply there's a drain in place, it's doing its job, it's catching the pancreatic fluid, and kind of no harm, no foul. Then there's clinically significant pancreatic leak or pancreatic fistula, which is divided into grade B and grade C, with grade B being someone needs antibiotics for treatment, so you're clinically doing something, or grade C, which is where a patient couldn't even need a new percutaneous drain, which is usually placed by interventional radiology. There are other considerations. For example, pasireotide is an octreotide analog that was demonstrated at one point in a randomized controlled trial to reduce the incidence of pancreatic fistula. However, a lot of other groups have repeated that similar studies and had difficulty showing a real benefit, and it is a fairly costly medication. Sometimes when there is a pancreatic fistula that's walled off itself in the vicinity of the anastomosis, but really isn't accessible to percutaneous drainage, we'll have our interventional GI colleagues go down and do an endoscopic drainage procedure, and that's sometimes a useful way to manage that.
Thank you, Dr. Sanford, for that excellent review, and thank you so much for being with us today. We got through a ton of great information about pancreatic ductal adenocarcinoma. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of pancreatic cancer can be found in the Washington Manual of Surgery.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 2.
We are Drs. Paul Wise
And Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Katharine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.